A disc herniation involves the tearing of annular fibers, allowing the nucleus pulposus to move. Patients with a cervical disc herniation present with neck and arm pain. Bilateral pain suggests a central herniation, while unilateral pain only suggests a lateral herniation. Neck pain can be a deep ache with a sharp burning, or it can be pain to the upper extremity that stays in a dermatomal pattern and can be accompanied by numbness, tingling, or paresthesia. Other symptoms the patient can present with include weakness, decreased range of motion, and muscle spasms. Cervical disc herniations typically affect patients under the age of 40. Patients over the age of 40 typically have pain due to disc degeneration. The pain is increased with coughing, sneezing, and bearing down, and is relieved by antalgic leans. The disc and its annular fibers and nucleus pulposus can all be involved in cervical disc herniation. The ALO, which is at the front of the vertebral body, and the PLO, which is directly behind the vertebral body, can be involved along with the spinal cord and the nerve roots exiting the IVFs. And the facet joints are all relevant. There can be a broad-based herniation, which covers more than 25% of the disc space, a focal herniation, which covers less than 25% of the disc space. The herniation can protrude if the base of it is wider than the distance it extends out from the vertebral body, or it can be described as an extrusion if the herniation extends farther out than the width of the base. It can be contained if it's contained by the annular fibers, or uncontained if the herniation isn't contained by the annular fibers. The orthopedic test that you would do, the cervical disc herniations can be due to a traumatic situation, either with a quick turn of the head or with a car accident. There can be an insidious onset brought on by postural stress, or a herniation can be brought on by microtrauma with flexing. A herniation at the 4-5 disc level can produce weakness of the deltoid and wrist flexor muscles. At the C5, C6 level, it can produce weakness of the biceps and wrist extensor muscles. The C6, C7 is the triceps and the finger extensors, and the C7 and T1 is weakness of the hand grip. Special studies that you can do to help diagnose include X-ray for trauma or to rule out degenerative joint disease or foraminal encroachments. MRI can be used if there's no response to care in 2 to 3 weeks, or if symptoms worsen, and you can view the extent of the herniation. Or a CT scan can be used for severe cases to view bony malformations. The primary orthopedic test would be Jackson's compression, which involves compression in the neutral position and then both lateral flexion positions. You are looking for a positive test, which would result in the reproduction of the dermatomal symptoms. It can occur due to the narrowing of the IVF on the side of lateral flexion. It would compress the nerve root and facets. The contralateral side would have stretching of the muscles and ligaments, and it would enlarge the IVF on that side. Other orthopedic tests that can be done, nerve root tension tests such as shoulder decompression or Bacodes, or a space-occupying lesion meningeal test such as de Journey's triad. Treatment options include chiropractic adjustments just to the patient tolerance, acute herniations that would utilize rest, ice, and anti-inflammatories, or subacute herniations, you would utilize rest and heat. E-stim can be used to decrease pain and inflammation. Bracing or taping will lessen pain and muscle spasms. You could use some strengthening or postural exercises, but you would need to seek a surgical orthopedic consult if there is a hard lesion compressing the cord or nerve roots, or if there is an upper motor neuron lesion sign. I'm done.